Regarding proximal humerus fractures, whenever describing an X-ray, it's important to describe the Hertel criteria. The Hertel criteria, the most important predictors are more than 8 millimeter of calcar length attached to the articular, less than 8 millimeter of calcar attached to the articular surface, disrupted medial hinge more than 2 millimeter, and basic fracture pattern like anatomical neck fractures. These should be explained. A main blood supply of the proximal humerus is circumflex humeral artery. Near classification should be remembered with the surgical net, anatomical, surgical net, greater tuberosity, lesser tuberosity, head and shaft fractures. A plain radiograph should be advised as well as X-ray view, as supraspinatus pulls the fragment posteriorly. Regarding the operative management for the pediatric population, there should be non-operative management. Less than 6 years, any angulation should be accepted. Aim of angulation is 30 degree of angulation, transmission of less than 50 degree, and adolescents 11 year, more than 11 years old. ORF is advised if there is more than 1 centimeter of angulation, or most 1 centimeter of displacement, or 45 degree angulation. Number 2, 4-part or head splitting fracture in young, anatomical neck fracture, valgus impact fractures, and fracture displacement. Regarding the operative decision, I would decide with respect to patient condition and the fracture condition. Regarding the patient, the most important factor is age. Younger population would need open residential fixation, while the older population we can do conservative, or it might need a revision surgery in a form of reverse shoulder replacement surgery, because the cuff is not intact and mostly it's injured. Regarding the fracture factor patterns, the Hertel criteria is important. Less than 8 millimeter, of calcar attached to the articular surface. This means short calcar. Number 2, displaced medial hinge. Number 3, basic fracture pattern like anatomical neck fracture, or a head split fracture, or a valgus impact fractures, or fracture dislocations. These are the indications for operative intervention. The type of approach can be deltopectoral or deltoid splitting approach over graded trochanter fractures. Mostly I would prefer the deltopectoral approach. The principle of fixation is: number 1, head neck shaft angle should be restored. Restore graded trochanter and greater tuberosity, lesser tuberosity, and repair the cuff. A locking plate, when fixed, it should be lateral to the bicipital groove to avoid the injured ascending branch of anterior circumflex humeral artery. Inferior medial calcar screws should be placed to avoid varus. A humerus locking plate or a clover leaf plate can be used. Tension band wire is used or screws can be used in the young. Non-absorbable screws should be used for osteoporotic fractures. A nail violates a cuff. Shoulder pain is the most common complication after the surgery. Biomechanically, it's inferior with torsion stress compared to the plates. Otherwise, favorable rates of fracture healing and range of motion is also noticed with nail. So the most important factor difference in nail and plate is that biomechanically nails are inferior with torsional stress compared to the plates. Hemiarthroplasty can be advised for comminuted 4-part fractures or head split fractures in elderly with poor bone quality. Unreconstructible in young, high-demand individual. You have to avoid retroversion. The problem with the hemiarthroplasty is that if the patient has poor cuff conditions or there is non-union of the tuberosities, then it ends up into a point of no return, where the operative intervention will be very difficult. So there was a PROFER trial which showed it's a proximal fracture of the humerus evaluation randomization trial published in 2015. 250 patients were randomized into 2 surgical groups, fixation or arthroplasty, and clinical outcomes were measured by the OSS score in 2 years follow-up. Majority of the patients were 2 to 3-part fractures up to age of 66, age range of 24 to 92. Excluded patients with fracture dislocation, open fracture, comorbidities, precluding surgery, anesthesia difficult. The problem with this trial was heterogeneity. The young to old population were all added up together to put them in the trial. There was low recruitment rate. Some of the patients had to go on for surgical intervention, and the results in 5 years also have not changed. And then there is another. So the surgical group shown no significant benefit in PROFER trial when compared to non-surgical treatment in patient-reported clinical outcomes at 2 years. Similar results have been seen in 5 years. Reverse shoulder arthroplasty is indicated when there is non-reconstructible tuberosities. It applies on Gramont principle, medialization of the center of rotation to make the deltoid functioning as a cuff. The complications are AVN, 75% is in 4 parts fractures, rotator cuff injury, arthritis, adhesive capsulitis, intra-articular screw cutout, varus malunion. Shukla et al. 2016 showed that hemiarthroplasty comparison with reverse shoulder arthroplasty. Reverse shoulder arthroplasty gives better patient-reported outcomes. Regarding the deltoid approach, beam beach position, fluoroscopy prior to the final positioning. Landmarks are deltoid deltopectoral groove, lateral border of bicep brachii, internal splint created with the pectoralis major and deltoid. Cuff down reaching the clavipectoral fascia. Extension is distally along the lateral border of bicep. Cephalic vein is identified and retracted. At that time, you have to identify the long head of bicep in the groove to identify the greater tuberosity and lesser tuberosity. The lesser tuberosity goes with the subscapularis.